So we talked about, what obesity is as far as BMI, as far as body fat percentage, but what are the actual implications that obesity may have on a woman's body? Welcome back to the channel, everyone. We have Dr. Mercado with us today.
Hi.
And why I'm bringing her on the episode today is she is a specialist in not only OBGYN, which I work with her at our hospital, but also has a further board certification in obesity medicine, and also has interest in menopause and midlife health, which she also had certifications for. So quite the resume. Welcome, Dr. Mercado.
Thank you. Glad to be back, even though the first time
This
didn't
is
count.
the first time. This is actually the second time we're recording because, unfortunately, we did not finish our first episode because she was called away to an emergency.
Yeah.
But yes, we're going to have two episodes. One where we're talking about kind of the discovery of, what is obesity? What is all these different definitions you might hear for it? We're going to clear it up. We're going to talk about how it impacts specifically women in their healthcare and the different impacts that it has. And then on the second episode, we'll talk about a lot about treatment options that you do in your clinic.
Yeah.
Dr. Mercado not only is an OBGYN working here at our hospital, but she also works in telehealth, a company called Inclusa Health.
Yes, Inclusa Health and Wellness. So I do most of my visits, or all of them, telehealth through them.
Okay.
Yeah.
Cool. And you take insurance in that.
Yes, we do take all
And
insurance,
so-
most insurances.
I know. Well, and so you can check with her, Inclusa Health
And wellness.
and Wellness.
Yes.
.com.
.com. Yeah.
Okay. Or just Google that.
Yeah.
All right. So let's maybe start simply, or not so simply, with the definition of obesity.
Yeah.
Is it a number on the scale? Is it BMI? Is it body composition? How do you define obesity?
So in modern medicine, our standard is to define obesity based on BMI. Even though BMI is not necessarily the most accurate measure we have, and it was based after collecting data of a lot of male patients, young male patients in back in the 1940s, so a long time ago, basically. And we know that in the U.S. the population has changed a lot ever since. So unfortunately, in the medical world, we are still stuck with BMI, especially when it comes to like clinical trials that are done and insurance criteria
And
to define BMI and who qualifies for what medication or treatment, etc. So overweight is classified as BMI between 25 and 29. And then obesity class 1 is between 30 and 35, or 30 and 34.9, sorry. Class 2 between 35 and 39.9, and then class 3 is above 40, BMI of 40. But there are other ways that we can assess also BMI, not BMI, but obesity. One is abdominal circumference. So that is something very easy patients can do at home. They can measure their abdominal circumference. And another one would be a little more challenging, but it would be doing a body composition scan and seeing what's your, total body fat percentage, visceral fat, and muscle mass, which ideally should be done in most people because it's a more accurate way to know like what's your health. The more muscle mass you have, the healthier you should be. Also, the less visceral fat you have, the healthier you should be in the long run, because those things correlate to like disease.
Okay.
Disease incidents and adverse outcomes.
And so if we were to break down and go back about these three measurements that we just talked about, BMI, abdominal circumference, and body composition in some way. BMI, that's calculated mainly by obtaining certain metrics?
Yeah, so BMI is very easy to do, and one of the reasons why it's so widely adopted and has been so widely adopted is just your height and weight. So it's a measure correlation between your height and weight, and it gives you a body mass index, that's BMI. But it doesn't necessarily tell you what's your body fat percentage. And a good example that you may hear about in social media are athletes or bodybuilders, right? The bodybuilders weigh a lot, so they may have a high BMI, but they have a very low fat body fat percentage. So in a way, BMI is not representative of your true health.
Yeah.
But I have to say, in clinical practice, on what I do, I think it's a very good measure. Most people that I see are obviously not bodybuilders or athletes.
Yeah.
Otherwise, I wouldn't be seeing them.
Yeah. Do they have differences yet on healthy BMIs, or do they differentiate at all between the BMI in a man where it was studied and a woman now?
No, so it's those numbers are universal across the board for men and females above the age of 18 years old. So there's a different metric for children or, less than 18 years old.
Okay. The waist circumference or the abdominal circumference you mentioned, where would someone measure that exactly on there?
So it's not at the umbilicus as you may think. It's at the level of the ischial spine. So it's like you have to have someone measure it for you, or you have to look in a picture where exactly you do it. So it's like a little above your pelvic bone.
Okay.
Slightly above your pelvic bone. So between your pelvic bone and your umbilicus. Okay. This can also be a little tricky because it can be different based on ethnicity. So the cutoffs for Asians is a little lower than the cutoffs for Caucasians. And also for Hispanics maybe a little higher. So that is also ethnicity dependent. So we don't use it as much. But it's another way for the patient to understand, how do I say this, to measure progress. If someone's under treatment, we not only want to look at a number at a scale, sometimes you make progress by losing inches and not necessarily weight, especially if you're working out, right? So it's another way to tell patients, it's not all about a number and a scale. It's also about like centimeters, inches, and body fat percentage.
And then body composition, which is probably the most useful.
Yes.
I think that in some way when we see patients and not only see the chart and we see the BMI, but when we evaluate them, we kind of know, there's other factors that let us know, is this person a BMI of 30, healthy BMI, more muscular versus more fat? We can kind of do that when we're seeing evaluated patients, but there's other ways that are more, they give us a metric for that, for measuring body composition, and that would probably be, you see like those pinch tests where there's the different areas where you can pinch with that scale, and this is what I think the gold like standard for figuring out body fat, and especially for like bodybuilders, things like that. I think traditionally you've used this, but now there's some newer ways to do it.
Yeah, so the most accurate way to measure body fat percentage, it's something that realistically is never going to be done on most people, right? It's like MRI or
DEXA.
No, the DEXA, it's actually nowadays very accessible and affordable. Yeah. But you're not going to do MRIs on most people, right? So the three most accessible ways that we have is the caliper version that you mentioned. Although the person who is doing it really needs to know how to do it. I'm going to be honest, I've never done that. I don't know how to do it. Now, the two most accessible and more accurate one is a scale that you kind of hold handles. It's like body impedance, electrical impedance, and it kind of calculates your percent of body fat, muscle mass, water, based on the impedance of that electricity that runs through your body. So the most common machines are the InBody, and there's another one called the Seca. So a lot of gyms have it, and a lot of like spas, or I would think like on this day and age, most medical practices should have it. So it's just a scale you step on, and then you hold the handles, and then it will print out, your body composition. And then the second one would be a DEXA scan, which is imagine like a very small a CT scan machine or an MRI machine on a very, very, very small scale, and it doesn't take that long. So you're just like laying flat on a bed, and then the top of it scans your entire body. DEXA scans are commonly used to measure bone density, but in calculating that bone density, they can also see your total body fat, your muscle mass. And the good thing about the DEXA is that it can also see your visceral fat. Like the caliper and the scales do not differentiate like how much of your total body fat is on your visceral fat, which visceral fat is the one that has been associated with a lot of like cardiovascular disease and metabolic diseases. So the DEXA can give you your visceral fat, which is really good. I've done DEXA scans. You can get them for like $50. Mm-hmm. It takes about like less than 15 minutes total. And there are, even mobile places. Basically, they're inside a van and then you just go and get it done. Mm-hmm. Super easy.
Yeah.
Yeah.
Great. And you mentioned visceral fat. And so I think there's also probably a way to know, is somebody with extra adipose tissue, when is it actually becoming unhealthy?
Yeah.
And visceral fat, I know, like detecting how much visceral fat they have, which is the fat around the organs within the abdomen. Yeah. Like if we do a surgery, let's say we're doing a tubal ligation surgery, a laparoscopic surgery, we can see, is there increased amounts of, there's no way to completely measure it that way, but, mm-hmm. Is there increased amounts of fat around these tissues, intestines, the different spaces, and so, at one point, do we know, like, is there a way to tell, okay, somebody has fat, but they're actually doing okay? At what point do we know when that fat is starting to really cause metabolic disease and detriment to their health?
Ideally, for a female, you want to have a body fat percentage less than 25.
Okay.
For males, it's more around the 20%. Females always carry a little extra fat, especially in their hips. Mm-hmm. It's just genetics or. And
so they have kind of a different understanding of what a female should have, what a male should have for the body fat. Not as much for the BMI.
Yes.
But this is a way to differentiate.
Yes. So at least for when it comes to body fat percentage, we do have more specific thresholds for men and females, right? Mm-hmm. So having said that, you also have to correlate it with, your muscle mass and your bone mass, mm-hmm. which is your fat-free, total fat-free mass that, you mm-hmm. have in your body. But generally, ideally, women less than 25, men around 20, less than 20. But so that you have an idea, bodybuilders are usually at a 8 to 10%. Like if you see someone competing, last day of competition, they're usually at a 7, 8, less than 10% body fat, so mm-hmm. that you have something to correlate. Athletes are usually in the teens.
Mm-hmm. Okay.
And so, if you have someone who has a high BMI and you are able to do a body fat percentage and you have high body fat percentage, part of our intake a lot of the times is also doing lab work, mm-hmm. Because if you know that these patients are going to be at higher risk for having metabolic diseases. So we always check some sort of measurement of your glucose status, whether it's an A1C. If it's slightly abnormal, a lot of the times it's worth it to do the 2-hour glucose test. We also do a lipid panel. We also always do like liver enzymes. Mm-hmm. So just basic lab work to see if there's any early signs of metabolic disease.
You see more and more people doing the continuous glucose monitors.
Yes.
I think, definitely has its utility for people, diabetes, pre-diabetes, things like that. And I think some people, it can be an information gathering thing, I guess, in a way to do this. Is that, would you say?
I think, let's just start with continuous glucose monitors. They are a little expensive, right? So mm-hmm. This is my take on all these things. If you have the extra money to do it, by all means, do it. I did it once. I wore a glucose monitor for 3 months, and I did get a lot of information. Uh-huh. Not a lot. I did get a substantial amount of information. For example, when I was on call and I didn't sleep well, my sugar was always high, right? Oh. So you can actually see the correlation with like your daily stress uh-huh. and like your sleep quality uh-huh. and how that can affect your sugar, right? That's something that I wasn't expecting to see as high, right? Yeah. Another one is, for example, things that are rice-based for me are not good. Mm-hmm. So now it's not that I don't eat rice noodles or rice. Mm-hmm. I do it. I just do it less often. Okay. Because again, if you have a normal physiology, you should be able to your body should be able to, digest it and regulate eventually. There are other ways. to do this. But is it like a make or break? I don't think if you have the means to buy it and wear it for a few months, I think you can get some good information about it.
Yeah.
But at the end of the day, that's not going to replace all the basic things that we need to do for our health. Good sleep, stress management.
Yes. Future
Future
podcasts, hopefully
podcasts,
holding, talking about all those
yeah.
things.
Movement and on processed diet, etc. Yeah.
And so I think it's probably, in this country we, you know, oh, weight, all these things are very delicate topics, but someone can gather information and do a little bit of their own discovery with some of these tools that you talked about, and it's fairly easy to do without even have to walk into a doctor's office.
Yes.
Doesn't say you shouldn't, because you mentioned there's lab work and other things like that to make sure that overall you're not developing like metabolic disease and things like that. Because we're going to talk about here in a second, so we talked about what obesity is as far as BMI, as far as body fat percentage, but what are the actual implications that obesity may have on a woman's body?
Okay.
Because I think potentially, especially in this country, for years we might have a higher BMI, higher adipose tissue percentage, fat percentage, and then eventually we might notice some changes in how our body is acting with all of those, and maybe not even completely correlating that irregular periods and extra adipose tissue, or difficulty getting pregnant, or and infertility and things like that. And so let's go through some of how this might affect a woman's body.
Woman's life. So in the past 35 years, or I would say since the 1970s, the obesity rate in the U.S. has increased steadily. Last year was the first time we saw a little dent on the
Really?
rate.
I didn't even know
Yes,
that.
yes.
Okay.
Because of GLP-1s.
Ozempic?
Yeah.
Okay.
It's the first time if you look at the graph, it's the first time that the obesity rate did not go up, right?
Okay.
So
Wow.
let's just put that out there. So it is a reality, whether we like it or not, right? It's not about judgment. It's just a reality, and we have to.
It's good to have the information.
Yeah, it's good to have the information. So multiple things, in general, whether it's female or male, obesity is now the second leading preventable cause of cancers. Number one is smoking. Alcohol used to be number two. Now obesity is number two. Alcohol is number three, right? And pertinent to women, we have uterine cancer and ovarian cancer. So we already know that obesity is, if not the biggest, one of the biggest risk factors for uterine cancer.
Okay.
So, I think when I was a resident, which was a while ago,
A couple years.
the thresholds of doing endometrial biopsies on women who were obese it's a lower age, right? So that's one thing. Second, you mentioned infertility. It is known that obesity is a risk factor for infertility, right? And irregular periods. The reason being, for the most part, I think we may think of adipose tissue as just tissue that's just there sitting around, but adipose tissue is very metabolically active, right? It secretes hormones, and it has enzymes, and it secretes like all sorts of cytokines and intracellular mediators and communicators like interleukins. So a lot of these secretions that the adipose tissue has are very pro-inflammatory, right? And therefore that's where you get a lot of the cancer, inducing, like factor.
So can we go back to that one statement you said right at the beginning? We think of smoking as the ultimate pro-cancer thing that's going to cause cancer or risk factor. And alcohol was number two?
Yeah.
And so obesity
is now number two
over alcohol.
Now as of recent, not like right now, but
right. But
it's been a while,
As of recently, obesity causes cancer at a higher rate than
alcohol.
Things like alcohol.
Yes.
Okay.
And it's associated also with more types of cancer. I think smoking is about 7 or 8, and alcohol is also about 7 or 8 cancers. Obesity is about 14 types.
So obesity increases somebody's risk of 14 different types of cancer.
Yeah.
Specifically for women, and this is probably the most common one that we see, is
Endometrial. Yeah.
cancer,
Yeah.
which is the lining of the uterus, because that normally sheds in a monthly menstrual pattern. If the metabolically active or hormonally active adipose tissue is continuing to signal with the excess estrogen to the uterus,
Yes.
bleed and bleed, and eventually those cells make a mistake, and
So
which
it's
is
like
a
a
precancerous change. Go ahead.
no. So we have one which is like the adipose tissue secreting all these cytokines, right?
Uh-huh.
That are pro-inflammatory. So
Okay.
that's one part of it. The second part of it you just touched is that we know that adipose tissue also is metabolically active in converting testosterone to estrogen, right?
Okay.
Because it has the enzyme aromatase.
Mm-hmm.
So obese women have higher levels of estrogen, and we know that having unopposed estrogen or having high levels of estrogen where you don't have enough progesterone, it is the number one risk factor for developing endometrial cancer, right? Because it's then you're constantly signaling the uterine lining to grow, 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 grow. There's nothing checking it, and checking it, or there's no balance.
Yeah.
And that at some point cells make errors, or it's just too much stimulation, and that will lead eventually to endometrial cancer. That's why unopposed estrogen is not good, whether it's because of obesity, whether it's someone on hormone replacement therapy that has a uterus. If you're on estrogen, you need progesterone. Whether it's patients in PCOS that we now have, cycles where they don't ovulate every month, and therefore they have that unopposed estrogen, high
Because
estrogen status.
if someone's ovulating, meaning their cycle is working at that point normally, they form the corpus luteum cyst on the ovaries, the normal cyst that secretes that progesterone, and that's
Yes.
the
Protective.
protective thing for the uterus that we were talking
Yes.
about.
And if you don't get pregnant, right, both hormone levels go down, and that's when you have a period. So you shed all that uterine lining that has been growing. It's going to come out, and then it all starts again. So yeah, you always need that progesterone, but you also need the level hormones to go
Fluctuate.
down, to
Yeah.
decrease, so that you can.
And so if you're
Shed.
always increasing that amount, not having the normal fluctuation of a
Yes,
cycle,
yeah.
that also increases the risk. Specifically with excess adipose tissue or obesity causing other women's health cancers. I think breast cancer
Breast.
is increased with obesity.
But breast also can be breast cancer. Part of it can be attributed to like those high estrogen states.
Yeah.
Yeah, and again,
Pro-inflammation.
pro-inflammation, and the other cancers are obviously in men prostate, but all the others are, in both men and women.
Yeah.
Like thyroid, pancreas, gallbladder, colon. In men, prostate.
There's also pregnancy complications, which
Yes.
you probably see a little more than I often now, since I don't do as much pregnancy care. But not only can change, they're with really high really high glucose levels, things like that,
Yes.
can affect a pregnancy. Gestational diabetes or type 2 diabetes during a pregnancy, large birth weight, which can have
Labor
delivery,
dystocia. Yeah.
delivery complications, which can be pretty scary.
Yeah.
So that and increased surgical risk.
Yes. Also, surgical risk. Not only is surgery being more difficult, it lasts longer. All the
Lasts
things that come with
longer,
that.
it's harder on the lungs, and so recovery afterwards and moving afterwards can be harder. And then with obesity and someone maybe not feeling like their best self, I imagine there's a lot of negative mood symptoms that someone
Yeah,
could
yeah.
experience with obesity. So
Yeah, I have some patients that, are embarrassed to go to the gym. They know they have to work out, but they're embarrassed to go to the gym, or they don't want to wear certain clothes, or,
yeah,
you know.
and I think a lot of people struggle with this a lot more before they even see somebody like you.
Yeah. These are just, examples,
Yeah.
easy, simple examples, things that we may not think about on our daily life, but, they do affect you.
So, if somebody is in their discovery phase and wants to know, do they have extra adipose tissue or obesity, and they do some of these tests that we talked about, and they talk to their primary care, I imagine.
Yeah.
And I think some primary care doctors do deal in obesity medicine, but are there other ways? Like, how could someone discover a person like you? Like, if they're ready to take that
Then,
first step to
okay.
helping themselves, how do
Yeah.
they find out?
So, primary cares are always our first line of defense in medicine, right? So,
Mm-hmm.
ideally, if your primary care has enough insight, they can say, oh, if this is something that they can tackle or not. And if they not,
Mm-hmm.
hopefully they can get referred out to, there are most hospitals, most centers, like Valley, UW, Multicare, Providence in the area, they all have an obesity clinic or a lifestyle
Yeah.
lifestyle
Yeah.
clinic that they can get referred to.
Yeah.
That's one thing. Unfortunately, I would have to say we see a lot of patients that are referred to us by orthopedic surgeon because they need a joint replacement and they need to lose weight beforehand, or by a general surgeon because they need some hernia surgery or something, and they won't do it unless you're below a certain BMI. So some people do get referred to us once they get to that level. But the other way to look for someone, if you want to make sure the person you talk to is a little more legit, or you can go to the obesity medicine website. There's the American Obesity Medicine Association, and you can find a list of the doctors that are board certified on obesity medicine.
Yeah.
Yeah, and the Board of Obesity Medicine also, their website should have a list.
Okay.
Just the same way that like the Menopause Society has a list of
Yeah.
the doctors that are certified in menopause. Yeah.
Okay. Well, that's awesome.
Yeah.
That's our first episode,
Oh.
Dr. Mercado. We have another one coming.
All right.
Thank you, everyone, for listening and watching. And we'll be back soon with Dr. Mercado, and we're going to talk about different treatment options someone may have from a medical standpoint for obesity.
All right.
All right. See you soon.